Okay.
I'm just going to introduce Patrick first, then I'll get through Patrick the rest of the panel. So many of us in the room know Patrick. He's been Regius Professor of Physics here since 2012. One of his many jobs is to develop the university's research and education activities on the biomedical campus. And you can see that things are happening apace on that when you look at, say, the pending opening of the Capella building, the biological research facility known as Bellatrix, and so on and so forth. A hell of a lot of growth, a hell of a lot of exciting clinical science development. Patrick's done this sort of thing before. He had important roles at UCL, where Charlie is, but also at Imperial prior to coming to Cambridge. And again, as many of you will know, he has a distinguished research record personally in kidney disease. And he sits on the boards and committees of loads major funding and research charity organisations. And he still finds time to do the odd renal clinic in Addenbrooke's Hospital. So that's Patrick. Patrick, thanks very much. Over to you and to your panel.
Okay, so I'm going to get the panel to introduce themselves. Who'd like to go first? Actually, before that, one other thing I do, which is one of the most enjoyable things I do, is I'm on the board of a FTSE 100 investment trust. And actually, I've found that enormously exciting. Who'd like to go first? Jane.
So my name's Jane Osborne. I'm head of R&D for MedImmune in the UK. MedImmune is part of AstraZeneca, so we make protein-based therapeutics. I've been living and working in Cambridge for over 25 years. I've got a background in biotech, was part of Cambridge Enterprise Technology, and have grown up through biotech, big biotech to pharma. I'm also chair of the UK Trade Association for the Biotech Industry, the BIA, so I have a bit of a sort of insight into some of the challenges of the smaller companies collaborating.
Excellent. So the introductions to me and Jane were a bit on the long side, so a nice crisp introduction from Roland.
Roland Saintberg, Chief Executive, Cambridge University Hospitals and Interim Accountable Officer for the STP.
And next, I think, is Jazz.
Afternoon, everyone. So I'm a clinician by position that clearly. I'm a clinician by background and an associate partner for IBM's healthcare and life sciences practice.
And then we're going to go to Mark.
Good evening. I'm Mark Cruiser. I'm the director of the PHG Foundation, which is a health policy think tank here at the university. I'm a consultant in public health medicine and have worked in the NHS, but not anymore.
So I'm Karen Lining-Jones. I head up Future Place at Roche Products in the UK, which is basically how we work longer term with partners like CHUP and how we look at personalised healthcare. And I am a non-clinician, so I think I'm here to represent commercial.
Very good. And last but not least, Piers.
Thank you, Patrick. Piers Ricketts, Chief Executive of Eastern Academic Health Science Network. So a little bit like the organisation that Charlie works for, helping to support the adoption and spread of innovation. Been in the role about 6 months. My previous background is in management consulting with KPMG. Thank you.
So that's the panel. I have to be frank, it's not entirely clear to me what the question is that we are most equipped to address, but given the breadth of the panel, you could see that we could tackle any question you wish to throw at us. We have some starters in front of us. Put any other questions up there or coming from the floor. But while we wait for that, I'll pick one of the ones that we were sent in advance. So the first one, you say the NHS is working with industry and research effectively, but how do really busy doctors, nurses and managers actually get involved in practice? And I'm going to look at Roland for this.
Thank you very much, Patrick. So I think many are already. I think that the business of improvement, partnering with industry, partnering with the university partners is pretty integral to what people do as their day job every day in the National Health Service. I think in the case of both the STP and all of the partner organisations in Cambridge, we all have heavily resourced and well-led programmes of improvement and transformation, which is freeing up people's time to work in the sort of way that we've been talking about, I think, in the first half of the session.
Excellent. And I mean, if you were to, I think you've got about 10,000 people in. What sort of proportion do you think are actively engaged at the moment in the kind of partnerships we're thinking of today?
Right. So to give you a sense of scale, if we just look at the consultants, so the most senior doctors in Addenbrooke's, we have 620. Okay. And that is I would say a comparable sized hospital in the UK by turnover would have probably more in the region of 300 to 400. Okay. And that is because many of the consultants in a hospital like Addenbrooke's and the Rosie are actively involved in research or partnership with industry. So I think it's a much more research and industry active health and care system than you would find in other parts of the UK.
And then, perhaps looking at Jazz and Jane and Karen, I think some frank observations on how you see the NHS in general looking into it and what you'd like to see it do differently. Perhaps, Jazz, you'd like to start on that.
I think a significant challenge, I think, broadly speaking, for industry. So I've taken up my role with IBM sort of month 5.5 in, really. And prior to that, sort of worked with Deloitte, so have a extensive consultancy background. And I think if I sort of look to my experiences and sort of liaising with my sort of peers in industry, they are often challenged by how to navigate the NHS. And I think it's often the bureaucracy which acts as a great deterrent to actually wider engage and collaborate on initiatives that potentially could be a win-win for both parties. I think in terms of actual outcomes and actionable insights, as actually providers should probably engage with industry a lot earlier than they do. I think most of my conversations with providers tends to be a lot later on in that journey. By engaging early, you are enabling to build a relationship that's actually really transparent. And I think it comes down to building a relationship, actually, not about selling services or just getting revenue out for either businesses. And I think that's absolutely pivotal because often industry makes, I think, assumptions of actually what those challenges are, no matter how small or big they are relevant to industry.
Thank you. And Jane?
Yes, so I'd say that I think we have some really good collaborations, and I think at a national level from AZ, looking at patient care pathways at regional levels. I think what's working really well is actually grassroots engagement. I think our scientists and our more sort of people working on real life problems are very good at connecting, and I think the Cambridge environment is doing a really good job of stimulating that. And I think we have a very strong joint collaborative culture at senior leadership level as well. I think the piece that we need to work on is having the right conversations in the middle to define the best problems that we jointly solve. And I think that's the piece that is difficult and actually takes time. It was nice to see the 2-day ideation ideas. I think we have to make the investment of that time to define the appropriate problems and get them aligned. So.
And it's not completely simple, is it?
No, it isn't. And we all want to do it. So, yeah.
Roland, another comment?
Yeah, so I think that the NHS has still got a long way to go, though, or health and care more broadly has got a long way to go to make itself, Tracy, as you put it, open for business in the way John and Malcolm, we heard, where Royal Papworth, I think, are getting to at the moment with Philips. I think there are two ways into this at the moment for the NHS. The first is we are very committed in Cambridgeshire and Peterborough to creating a properly integrated health and care system that I think will get us much, much further upstream and closer to the patient in terms of tackling many of the issues, Tracy, that you were talking about. So Gary Howsam, as chair of the clinical commissioning group and a GP in the area, is here this evening, and is central to how we will build what we're calling, I think, 19 neighbourhoods across that population of 1 million. And it's much, much easier for hospitals like CPFT, Royal Papworth, Addenbrooke's and the Rosie to interact with 19 organisations that integrate health and social care and the patient and the population. And I think that underpinned with data, and Charlie, your plans around Lycra, I think we're replicating exactly that here, will let us do things, I think, in a much more constructive and positive way for the patient, to sort of skip a couple of generations and avoid the large number of acute hospitals that we could end up building. I think the other piece, to go back, Steve, to your comments around the long-term plan, there are some very clear gauntlets being thrown down for all of us there. So on cancer, how are we going to get into much earlier diagnosis and move from stage 4 to stage 1? And how are we then going to bring all of our expertise to bear in terms of precision medicine to look after those populations in a different way? Now, health and care can only do one part of that. Industry and the university sector can help us tackle that in a way that we are already. And I think the partnerships with Roche and AZ, MediImmune, Andy, we were on the phone last week on oncology, are going to be central to that.
Okay, and another comment on this, Karen?
I guess I would just add to that. I think one of the critical things that we've seen in terms of making collaborations work is actually senior leadership buy-in. So senior leadership sponsorship that allows people and gives them the permission to spend that time within their day job on these programs because they actively want to get involved. But if they're being drawn in a million different ways, that's not going to make it possible. And I think the really critical thing, and Jane's right, this is about crystallising what the problem is that we're jointly trying to solve. And I think lung is a great area. So we've had a long-term collaboration with Somerset, and what we've been able to do is show that actually 40% of care in their lung pathway is unplanned, and create a model that we can take to other centres that show how you can remove that and reinvest that to really sort of help. But we only came up with that because we were looking to solve the same goals, and we were really open about, actually, one of their big challenges was a lack of radiographers. So urgent x-rays simply weren't happening in time. And it is really uncovering what those issues are to be able to address them.
Too many radiographers being good at running providers. Okay, so this looks like quite an interesting question. What recent development has had the greatest impact on people's health in the UK, and how did it come about? Mark. And meanwhile, I mean, I regard it as fair game to pick on the audience to answer the question as well. So think of your own answer.
Well, as a public health physician, I would have to say our activities with regard to smoking cessation, I think, has been successful. Although, as is outlined in the long-term plan, there's more to do. So I would certainly suggest, from a population level, that has been successful. And I think, how was it done? Well, it was cross-sector. It was based on lots of years of evidence, advocacy, against very sort of strong commercial interests and regulation as well. So it was a combination of all those efforts that really made that as successful as it is now.
And although successful, it seems to me that the NHS has been pretty resistant to the things that cost money but work in smoking cessation. I mean,
yeah, I mean, I think, again, sort of thinking about Steve's challenge on the long-term plan, there is, the cash is really tight, and there's this permanent battle between NHS England and the Treasury about, this is not being apologist, by the way, it's just come into it from both sides, having observed this, what some parts of NHS England are saying at the moment, that yes, you can come up with great innovative things like that, but it has to have a payback period of a year. And of course, that just doesn't work. It doesn't work for science. It doesn't work for expensive kit. It doesn't work for all sorts of things. And there have been some quite trenchant conversations between the 15 chief officers of all the AHSNs. There's a couple of, in addition to Charlie, a couple of other very distinguished clinical academics. It's quite interesting being on fly on the wall in some of those conversations. So I think, the money is tight. The way government accounting works for in-year payback just makes some of this really difficult. So you have to kind of find ways that you can navigate around it. It's not easy.
But I also think, we could do better on demonstrating the payback, couldn't we? So, showing that it does make sense to spend money on nicotine, replacement products.
Indeed, and I would just follow on from that. It takes time for that evidence to come through, and I think it comes back to Piers's point. In wanting that after a year is very difficult to evidence unless you really put a lot of resources into that short period of research.
It does go a bit to Charlie's point as well, though. I mean, if you build in the evidence gathering from the beginning, and you tell people when the evidence is going to come through, and we could do that better.
Yes.
Okay. Any burning questions from the floor? Excellent. Andy.
Patrick, thank you. I'd like to bring together, it's been great, by the way, and Malcolm, my apologies for arriving late, so not seeing the early stuff. But I'd like to bring something that you said together with something that Tracy said together that particularly hit with me. And you talked passionately about the fact that we're doing some really great stuff with people like Philips and big companies, and we've got to get better at building the rest of the ecosystem at the small and medium-sized and scale companies, which I entirely agree. And then Tracy made a very compelling point. Why is it when something works really well in one place in the NHS that it's then so hard to scale up? And for the very small companies, and I see business plans every day from stuff in digital health and digital therapeutics and medicine that's really compelling. And so often they have a champion somewhere in the NHS who is taking this in. And you get this problem that we see as investors, which we call death of 1,000 pilots, which whilst they've got one, and then they extrapolate to say, because we've got one, we'll get several. It doesn't happen. How do we get the pace for when there is a champion and we've got something that's shown that it works, that then it's so slow to bring it up? I don't have the answer, but it'd be great if there were some on the panel.
Yeah. So how do we actually get things to move out much faster once they're shown to work? Roland.
Yeah, so Andy, it's a very good challenge. I think there are existing mechanisms now in the NHS that we should be using much more assertively. So the STPs are bringing together in a much more structured way a community of providers within a particular footprint, typically around about 1 million people. And the leadership of those STPs will be expected to make the best use of taxpayer pound and spread innovation within those, as well as peers across a region. I think also in particular pathways, so cancer being the most obvious example, the way that we provide care is now much more mandated than it is in other pathways. And we need to piggyback off those sorts of mandated pathways in a way that's much more proactive.
Okay. So the STPs, strong possibility there, Mark?
I just would like to add that there is some experience and examples of implementation tools, and I think certainly NICE does generate those as well. And I think in part it's tried to answer the questions and allow local areas to actually input their local data and then answer some of those questions, which is forcing different areas to actually, try and run pilots, etc. So I do think there's a place for the development of more implementation support to try and avoid the sort of extensive piloting of the same question, these are not unique questions. I suspect that most areas are asking the same questions, but they just want assurance about their local context.
Can any of the panel members give a really good example of something where the implementation and take-up has been unusually rapid? I'm sure we can all think of ones where it's been unusually slow, but where's one where it went really quickly, and what could we learn from that?
Well, there's one that's going quite well at the moment, which is the atrial fibrillation screening program. Some of you may have heard about this. So the little mobile ECG devices, about half the size of a mobile phone. You can pick up people in primary care or in sort of non-clinical settings, put your 2 thumbs on it. The algorithm goes through and said, yes, you definitely haven't got AF, or actually you might, in which case you need to follow up with a 12-lead ECG. And there's a combination of the tech, the pathway, which was developed by Gary Ford, and there's 3 years worth of research from his team in Oxford behind that. The sort of mandated adoption, if you like, through the HSNs from NHS England, and a lot of the evidence, and because they're electronic devices, the data and all the readings are collected and you can kind of prove it. So that's quite a good example of how everything is kind of multiplying, but there's lots of factors that had to be in place before that. So you've got the tech, the pathway, the clinical evidence, the public health evidence, the involvement of community teams, plus the push for it through a national programme. So a lot of different pieces
So
in
the
place. but
mandated adoption, I
that
think
really
that's another
helps. Yeah.
important element, and we're going to have to get better at doing that. Jane?
Well, I guess the other interesting one, which is mentioned in the 10-year plan, is continuous glucose monitoring. I think can be absolutely a phenomenal tool in terms of management of diabetes, and actually seeing the continuous monitor provisions for type 1 diabetics, at least I think that will become the standard of care, and I think that's incredibly powerful because that then sort of links everything around prevention. If we get the data connectivity and integration right, we'll start seeing real insights into how we manage diseases in a more iterative way for diabetes, and I'm very excited about that opportunity. So.
Karen, would you like to add in that sort of, Karen? No, Roland. No, I'm giving. I think I've heard enough from Roland for the moment.
So I think
he's a great friend. We've talked a lot.
I see what they mean. You really could do question time. I think from my experience, what happens is you're right. You do end up with death by whatever the right number seems to be, and there's obviously varying numbers as to whether 13 gives you a representative before you have to go to all of the hospitals and scale it up. I think what we need to do is we need to look to the technology industry and say actually what they do is they trust that they have proven it in a certain sector and roll it out and make it work, and to Jane's point around iteration, actually sort of embed it and trust that actually you can make it work for the local area and really believe in that, I think.
Sorry, Roland.
Don't apologise. We do spend a lot of time together. Our offices are about 30 yards apart. So I think we have to piggyback, Patrick, off the back of existing assets or major investments. So within the Cambridge footprint, we have an electronic patient record called EPIC, which is well recognised. It's got Addenbrooke's to HIMSS level 6, which is the most advanced you can be in terms of digital healthcare in the UK. And what that enables us to do is to work with clinicians in and out of the hospital to say, how should we provide care in a standardised way to remove variation? And we can do that in all sorts of different ways. The other piece is in Cambridge now, with the opening of Royal Papworth, planned developments with CPFT, we have in addition now £100 million committed from government for a children's hospital for the Eastern region. So this footprint snagged 14% of the nation's allocation of capital for the NHS for 1% of the population in December last year. And that is something that will be co-led by the university, CPFT and Addenbrooke's. And that gives us the chance to design now a hospital for children for the Eastern region that's a different sort of a hospital. And we need to use that sort of opportunity to get the right partnerships and spread in, Patrick, in the way you're asking.
Okay. Any other? Yeah, Sabine.
Thank you. So my question for the panel is around really the title of the session today, which is about how the NHS will work better or differently with industry. And we have representatives from global industries on the panel, and I'm interested to know what the NHS, as a very unique environment, a very British experience, can learn from other healthcare systems around this particular topic. Thank you.
Yeah. So, Jane, would you like to start off on that? What can the NHS learn from other healthcare systems?
The healthcare systems. Well, I think the first thing to say is that we shouldn't underestimate the great, huge value and the potential of the NHS in terms of the data and the connectivity that we need to build. And I think we're doing a good job on that. We need to accelerate that. We need to do that faster. And I think what we can learn from other systems is more really around looking at how we share value and looking at how actually value moves around other healthcare systems to drive the right sort of improvements in healthcare. I think that's something that is complex, but I really do think that we need to think how the whole environment is going to change in terms of digitisation and data, and that we can drive that if we get that right. I think there are good examples of how that's being done in pockets around the world, but I actually think we're potentially ahead of the game there. So I think that is something that should be a focus for us, actually, particularly here in Cambridge.
Could you give an example around the world of where you think there is a pocket where it's going well and we could learn specifics?
Well, I mean, the sort of smaller populations. The sort of analysis that's done in Iceland from an R&D perspective is incredibly valuable. So I think where you've got relatively small populations, high quality data, we have got very high quality potential in terms of 100,000 genome information linked to integrated data. There aren't many examples around the world where that is the case, actually, in that sort of context. So.
Jazz, I imagine, from IBM and Deloitte, you've had quite a lot of sort of insight into other systems. What would you pick out as really excellent places that we could learn from?
Indeed, I think sort of taking it probably 10 steps back, I think actually sort of my reflection, sort of being a former clinician on the front line and sort of going into industry, is that actually there's lots to be learnt within the NHS. Actually, I don't think we've completely understood the great pockets of excellence that we have within our own system. And I think the next step is then actually looking across healthcare ecosystems outside the UK. So in particular, we've done some really great collaboration work between some of our UK NHS clients and our Nordics, where we're looking across sort of the integration of acute providers and primary care services, and what does that look like in terms of technology and adoption. Very much a work in progress is actually some of the work we're doing around health information exchange programs across the UAE, which again is across the entire region. So I don't think there is a kind of country or region per se that I could pick out in terms of absolute maturity that has what best looks like. I think there's pockets of that across that what I've seen in terms of my work across the spectrum.
Piers?
So I think the key thing that we don't have, which both to Jazz and Jane's point, I think it's the integration of the data with the supply chain. So if you take some of the HMOs in the US, for example, a particular example that my old colleague Mark Britton used to talk about was Claret in Israel, which is one of the HMOs. So you've got probably about 40% of the population and a very integrated but mandated by government linkage between primary, secondary care and the relevant data. So those are environments where you can do something because you don't have these breaks between different organisations. But again, if you take the long-term plan literally, that digital integration is mandated. It's amazing to have a Secretary of State for Health who actually talks about interoperability in his one of his first speeches. So that's got to find a way to happen. And I know industry is often frustrated with the amount of time it takes to get something into the NHS, by which often people mean right across the piece. But again, to build on what some of the other panelists said, there's lots of studies, including by the Commonwealth Institute, that says outcomes per pound spent. We are consistently sort of top three, despite all the things. So it's a different way of doing things that no one else has. But the answer is in the sort of integrated supply chain and the data, which maybe the STPs also will help to achieve.
So something I was very struck by in Israel was, at least as I understand it, there is an annual exercise in which basically new innovations are collected up across the entire landscape as proposals with costings, and then they're selected and prioritized. So if you get on that list, then it will be done by the HMOs, and that was an extraordinary thing to see. And it does mean that things can move to a sort of mandated status really rapidly. Roland, anything on this?
So I think we ruthlessly pillage every system we can think of for ideas in the NHS, as well as ourselves. So I would say on integrated care, what you would see in Frimley or in Northumbria is as good as anything that you would see anywhere else in the world in terms of bridging that gap, Piers, that you're talking about between primary, secondary, and in some cases tertiary care. I think many of the hospitals in the UK have spent quite a lot of time in the States with Intermountain, Virginia Mason, around improvement methodologies. And I think we've brought a lot of that content back into the UK, into the NHS. And I think some of that learning, Patrick, is being progressed by the This Institute, led by Professor Mary Dixon Woods. And Laurel and Malcolm have brokered a very strong relationship with Texas Medical Center, which I think is one of the strongest examples, Malcolm, isn't it, of industry working alongside a health system to be able to develop new innovations. So some good stuff in the UK, some great stuff overseas. We need to bring it together here.
Yeah, please.
Hi. Sue from the Association of British Pharmaceutical Industries. I just wanted to give you an idea of perhaps something to look at. So I think there's some great value-based healthcare work happening across Europe, and if you were particularly interested in looking for sort of different examples where they're demonstrating different models, perhaps take a look at the Martini Clinic work in Germany and some of the work they've done around prostate cancer, and that might give you a starting point to have a look at some different areas.
Very interesting. Okay, so we've got a question. I don't know if it's a question or a comment. It might even be an answer. Can you just wait for the microphone?
Hi, I'm Philip Smith from the East North Hertfordshire NHS Trust. We've seen some really fabulous stuff tonight, and I just wonder whether you feel that access to patient populations might be a limiting factor in due course with the expanding campus, and whether you want to think about accessing patients from nearby hospitals such as the Lister Hospital, which would give you a much greater capability. Because I note that the UCLP did that a number of years ago when they linked up with the Essex areas to give them access to a different and a large and a stable population.
Yeah, so, and actually one of our sort of advanced questions was, can Cambridge deliver effective collaboration by itself? If not else, what would it need? So perhaps we could take that with your question. And I think, Roland.
Thank you. So you're absolutely right. Cambridge alone, and actually our Cambridge STP, Cambridge and Peterborough STP, cannot deliver the scale of opportunity just by itself. Also, we have a pressing patient need across a much broader population. So to give you a very concrete example, in paediatrics, the children of the Eastern region are not adequately served at the moment. So the Eastern Region Children's Hospital I mentioned earlier, which we would anticipate would open in 2023, will need to think about how we support children across all of the hospitals and community services for a population of 5 to 7 million. I think that also, as well as improving patient care, gives us much more opportunity to partner with industry and the university to look after that population in a much more innovative way.
Yeah, Karen.
So I'm going to give a slightly different sort of slant on it, I guess. I think the other thing is that for research in the Cambridge area and to really sort of start to build meaningful data, actually you need a certain size of population. And for us to compete with places like Boston, China, I think we have to really get the data to connect. And that's going to require us to change the way we look at data. And it's a strange analogy, but I would look at mobile banking and how you get people to engage and give their data into that. Because I think we talked a lot around industry collaborating, a lot around the healthcare system, but actually we mustn't forget that patients are so critical to this, and we really need to work to engage them in the whole process. Otherwise, we simply won't achieve what we need to.
Yeah, so the data is really central. I think absolutely Lister should be involved, and it can deliver things. I mean, if you want to understand what happens to real patients, you wouldn't want to restrict. It has to be at a bigger scale than, Traces Trust, that's good population coverage of nearly 1 million people. That's not enough. I mean, 3 to 5 million, I think, is the minimum for this. And really our ambition should be to make healthcare across England a really usable system. And then I think we are competitive. A bit of a challenge is how you how you make it work in chunks where you can get people working really well together. And I think we have succeeded. I mean, particularly the recent changes in how the STP works here. I think we're getting to a good place with 1 million people. I think UCLP have done a really good job across a larger population, and we need to build out. Also, my view is, you know, there are many things that we heard from Charlie that we should obviously just join in with. Yeah. I'm not sure we're quite ready to just stop being Cambridge University Health Partners and be UCL Health Partners, but I was so impressed I was close to telling him we'd just give up our name and chip in. You mustn't quote me on that though, Charlie. Okay, question here.
I'm Dr. Takar, GP in Peterborough. So those population patients really are, and the future of the care has to be in that community.
Couldn't agree more. And you know, Roland's fed up with me saying that Epic is okay, but until we have primary care centrally involved in this, it's not going to deliver.
Just picking up something Tracy said about physical and mental health. As GPs, we never think of anybody with physical or mental health. They're just patients.
Yeah, and my understanding is that actually in the northern half of our STP, the relationship with primary care is substantially more mature digitally. Is that?
I think that's right, Patrick, and it's fantastic that you're here this evening. So I see a huge amount now of Neil Moder and Mustafa as they co-lead the development of the, I think as you know, what we're calling the North Alliance, which is really about trying to create in the north of the patch 9 of these integrated general practice, community services, social care hubs in effect. And my job from Addenbrooke's, and there's a similar job from North West Anglia Foundation Trust and from Tracy at CPFT, John and Stephen at Royal Papworth, is how do we give you the support that you need to look after that population in any of the specialist services that we provide. And that is going to be a journey for many of the services that have traditionally been provided in a hospital setting for our teams.
I mean, the beauty of Cambridgeshire is its diversity, but you need the northern part. Because we've got a north-south divide. But if we bring it all together, we've got great data sets.
Yeah, no, that's absolutely right. I mean, anyone else want to comment on this? I've started, you know, being the panel, which is not any good. So, Jazz, I mean, I mean, something that Jazz and I were talking about earlier on is I went over to West Suffolk. You know, you might not think of it as a university hospital in the same breath as CUH, but I can tell you that on this, it is really impressive. So in their partnerships with primary care across that region, they're doing really well. And it was neat. I mean, you thought they were most unusual across the NHS landscape. Is that right, Jo?
Yeah, no, and I think, I guess for several reasons, and I think sort of, I guess the most one that comes to kind of reference is actually the ability to actually have a very strong leadership board, not just within the 4 walls of its acute sort of boundaries, but actually really understanding that patient journey across the continuum. So actually we often sort of think of the patient as sort of being unwell, we diagnose and they go into our acute settings and they're back out again. But actually the patient journey starts very much at home and hopefully ends up at home. And I think what's certainly from my experiences with West Suffolk, that it's been very impressive from the outside, their engagement from actually the acute provider setting all the way to their CCGs. I appreciate they only have 2 CCGs, which makes it somewhat easier, but actually appreciating how critical that is, not just to patient outcomes, but actually for organisational outcomes has been particularly impressive. I would just pick up on that point around primary care and just community care services. I guess from an industry standpoint, I think that the 10-year plan is, I think, actually quite exciting from that perspective, because I think one of industry's significant pain points has actually been this absolutely needs to change, the direction of travel needs to change, and there isn't a strong mandate. So industry, I think, for the past few years has been battling up against this, and we are actively engaging with colleges like the Royal College of Nurses, like the Royal College of GPs, where in the past those doors have been closed. So I think it's a particularly exciting time for industry and very much open for business with those pockets of the community.
Actually, perhaps the critical advantage of the NHS is the primary care network, and we need to make that much more coherent part of the partnership landscape.
That was something that Piers and I was talking about earlier, around exactly that, of how can we do that and use the opportunity that these interactions provide to do that. Yeah.
I think a bit of a challenge, and I'd like us to be really frank with each other, even though we're on camera, is engaging all the GPs in a region is challenging. And I think people like yourself, Gary, can be really critical in this. Yes. I couldn't agree more. And it's one of the... there was a question about tribalism that I thought, Malcolm might pass on to the panel. And it's where we really need to make progress quite rapidly. And I think it's partly where Charlie was getting at with the sort of networks as the solution. This isn't about any of us, Roland or me, saying we should do something. We have to work as a network where it should come more from you than from us, I think. Okay, next.
Very much for the very interesting discussion. I am Marina Romanchikova and present the National Physical Laboratory. If you're wondering who we are funded by Department for Business, Energy and Industrial Strategy. We are also a government regulatory authority. We're part of the British Standards Institute. So we measure things, or we underpin the radiotherapy services in hospitals. I used to work in the radiotherapy department in Addenbrooke's for 6 years, and we were running the dosimetry services. What I have noticed, we are all bringing up these bits of a puzzle, and Charlie have noted of how important it is to have this data collection and how people for image analysis and DeepMind have struggled to cleanse the data. I'm sure IBM would be familiar with this. And while Addenbrooke's is making excellent efforts with EPIC towards the data harmonization, I also realize, as our GPs have pointed out, that a large point of data, this patient journey, is all coming from primary care. And at the moment, the exchange of information between the hospitals and the GPs is often through letters, unstructured text, non-standardized data formats. So we as a National Physical Laboratory, as a standards body, would like to work towards digital health and healthcare data standards. What kind of minimum quantity of information, what kind of information, in which format you expect to come from GP to the hospital to be able to quantify the information about the patient? Are you acting on this? What efforts are undertaken on this journey?
Well, we agree with your analysis, I'm sure. And Karen, can you? Karen and then Piers, I think.
I'll make a very brief comment, though it's not UK related. So Roche as a group, you may or may not be aware of, recently acquired Flatiron, who are a company that curate data. And it was fascinating to me, actually. I had a slight misconception around what they did. I thought it was all technology based, and then actually when I found out that they have over 900 nurses that basically go through data and abstract it and clean it and give it back so that it's regulatory grade, it really makes you realise how much technology can take us forwards, but you really need the people element of it as well. And it's a great point. Actually, I'm a patient, and my data can be seen if I come to Addenbrooke, so I go to West Suffolk from my GP surgery, and that makes a huge difference. But you're absolutely right, we need to make huge step changes in how that.
I was going to use exactly the same example, Karen. It's what John Bell refers to as the brown stuff that comes out of the back of hospitals, if any of you have heard of it, turning it into research-grade data. And there's something, whether it's regional or national, there's a real need for the kind of data scientists that you describe, because that's a big part of any digital program, and it's implicit in what's in the long-term plan. If that's going to happen, then what you're describing is exactly one of the building blocks that we'll need. Yeah, that's a good point.
I mean, I guess one other thing about it is I don't think we should be, when we're talking to industry, I think from an NHS standpoint, if we say that we have data that is going to magically answer questions, I don't believe we're telling the truth. And I think that is unhelpful. So I think in good partnerships, you need, a real commitment to truthfulness. And the fact is that turning the stuff in the NHS into useful information, because of what you say, would require tens of thousands of man and woman hours to make a start. And using more structured approaches is certainly part of the answer.
But sorry,
Karen.
I was just going to quickly respond and say, but I think that's where what we really need to define is what are the meaningful pieces of data? What's the data that we can actually show where there's a positive output or impact on a patient or the system, rather than collecting everything?
Yeah.
Sorry.
Absolutely right. Roland?
Yeah. So Mike Moore, the chair of the STP and of Addenbrooke's, is here this evening, and next week when he chairs the STP board, we will be agreeing a direction of travel to create what we would call an integrated health and care record that is not going to be the most perfect all singing and all dancing integrated health and care record, but it will make sure that the patient coming into clinic or the GP in practice will be able to access far more than they currently can in an integrated way. And for our population, that will improve the quality of care we can provide collectively. And that, I think, the view is the bedrock of everything. Beyond that, our success in the recent Digital Innovation Hub Exemplar programme, which was announced just before Christmas, Cambridge did superbly well, bringing together many partners in this room together with health and care, I think will be where we get into how can we turn grubby data or data in any form using things like natural language processing into something we can use in a much more proactive way with industry and the university. And I was delighted we were successful in that bid that was led by many of the people in the room today.
Yeah, and I think the integrated care record will not have everything, but what we do need to get to is a position where that has truthful, reliable information that is useful for the care of individual patients, provides a method of accurately sharing data between primary and secondary care, and people like the ambulance service who often need this information in a real hurry. Okay, I was told not to run over time. Okay. So, I think the question here.
Both Tracy and Charlie referred to workforce and workforce development, and it's in the 10-year plan. I'm just wondering what the panel's view or vision was, how the collaboration of industry and NHS can develop the next generation of workforce that's technologically savvy and supports innovation.
So I think this is going to be for Jane and then Jazz.
Yeah, I mean, it was actually a reflection that I think skills is something that we haven't talked about very much through the panel. I was going to say, I think it is a real opportunity for us. I think what we have within the environment that we work in is a massive opportunity for skills exchange. We're working on programs like the Experimental Medicine Initiative of sort of co-funding clinical fellows, but actually looking at how we create environments where we can have very genuine shared experiences and sabbaticals and different ways of working for skills development, and then also looking at the skills that we really need to focus on to solve the defined problems, particularly in the data environment. But I think we are doing a really good job within the Cambridge area of building up vocational skills, apprentices, and the PhD programs, postdoc programs, clinical programs, and I think we could do more of that. But I just think that really that actually is also the stepping stone then for shared understanding of how we progress the partnerships even deeper. So it's a very good question.
And Jazz, from a sort of different business perspective.
Yeah, I guess the sort of capability and capacity question is an ongoing challenge as it continues to be so. But I think from an industry sort of perspective, there's several platforms that we have now created or co-creating. So the first, I think, if I sort of reflect back, even as little as sort of 12 months ago, when we had engaged with clients, there'll be a resistance to co-creation. Most of our client conversations now are about co-creation. So there's a transfer of knowledge of actually bringing the best in industry expertise to our clients, and that reciprocal engagement, which benefits industry. That's in terms of tangible sort of real life example. My former employer, Deloitte, actually opened up a secondment program to the Royal College of Physicians and the Royal College of Anaesthetists to actually bring in secondees directly from the NHS. And there was about 5 or 6 of those which were extremely beneficial to those trainees, and they gained a lot. IBM is actively engaging with the Royal Colleges in terms of its innovation program. So my sort of recent conversation with the Royal College of GPs was actually, how does IBM support innovation across general practice? And what does that look like outside of just giving you a pot of money? What expertise do we need to bring to the table? So there is a lot of co-creation. I think there's a lot of appetite. I don't just speak on behalf of IBM, sort of the peers that I work with and the industry sectors are equally thinking of the same. So I think there's a real drive of actually how do we bridge that and how do we effectively deliver transfer of knowledge across both parties.
Good. So we've got a problem with the display screen, but there are a couple of really interesting questions here. So some in health academia perceive those engaging with industry as compromised. How do we think that, is my addition, and how do we embrace collaboration with industry while ensuring an ethical approach?
I can take that one.
Karen.
So, excuse me, I think this came up earlier in some of the presentations around one of the really important things around any projects where people are working together, any collaborations, is being really open and transparent and honest. And I think so long as we are very open, not just between the partners, but also to the external world around what the program is, why we're doing it, and who's involved, I think that's really the grounds that we need to do it. So I think you're right. I think there are some people who still resist working with industry, and they are concerned about what the perception is and what the perception will be on them as an academic or as a physician. But I think there are others who actually, once they've started to work with partners and they understand that we are being really open with them and we are really clear about what we're trying to achieve, that they also, if they have the same vision, buy into that and see what the benefits are. But I think it's about people and it's about building relationships, and you can't go into a room with a clinician for the first time and expect them to just trust you because you want them to. That's not how it works. It is about people and it is about being open.
I think one other thing I'd add is we have the huge privilege of working in something where we're looking after people, and we're not driven by profit. We're driven by, can we do good for patients, something that Tracy touched on and Charlie referred to. And I think when there are these questions of motives, if you go back to that, that's a very powerful way of bringing people together and bringing out the best in people. And I have been extremely impressed by industrial partners at their level of commitment to doing good for populations. And personally, I think it's rather a good commercial strategy as well. I think if they really do things that are good for patients, that ends up actually delivering very well on the bottom line as well. So I think using that as a touchstone is very useful. I think another aspect is for doctors like myself looking after specialist patients who can use a lot of resource. I think there's also this question, how can we go beyond just looking at the patient in front of us, who's going to be expensive to look after, and look at the best thing for the population as a whole. And that often takes you into it being better to prevent illness, thinking carefully before doing very expensive things that are going to make a marginal benefit, but thinking how you could do things, quite possibly through primary care rather than expensive tertiary care interventions. And I think we have a real responsibility in that direction. Roland, final comment.
No, so I think this is a vexed issue in that I think in a system like Cambridge or the examples we heard about from UCLP in north central London, I think that we can have exactly the sort of thriving relationships we're talking about this evening, which is terrific for the NHS, terrific for industrial partners, terrific for the university. What we've just got to be careful about is what does that mean for the populations who aren't immediately served by hospitals or colleagues in general practice or community services in areas like this. And if we are developing new and exciting innovations, how are those affordable for the taxpayer? And some of that, I think, Patrick, links to the life sciences industrial strategy, which is how do we make the UK the place to go to in the world to develop innovations for global health? And we've got to be the test bed with our patients for how we can do things differently. And I think that's a much more attractive proposition for the Treasury than, if you like, the black hole of NHS funding. And that's what we've got to, that's the sweet spot we've got to get to.
Well, I think Laurel should certainly have the right to ask a question, even though Malcolm is looking agitated. Malcolm, are you going to give your chair permission, or?
It's indeed. It's not a question. It's a follow-on observation, and that is, as someone who's probably sat on now 14 different commercial boards over the past 20 years, I've seen a big change in what companies are being asked to do by their shareholders, by the people who invest in those companies. And the question that gets asked now, and that this will be true of all of the companies that are represented on the panel, and people who from companies who are sitting in the audience, investors are now asking, what is your purpose? What are you doing that has meaning? Because that is what will make you sustainable. That's a very different thing than it was 20 years ago, when it was what shareholder value are you adding? The notion that of understanding stakeholders, understanding the impact on populations is completely changed. Yeah. And that has a sort of broader base. It's sustainability in all sorts of ways. We know that there's going to be more discussion on company boards around climate change and the environment, but equally understanding the impact on populations and their well-being is something that is meaningful. So I think that for people who are concerned about the relationship between business and delivery of healthcare, the world has changed, and it will continue to change. And I think for the better. And I think to support the sorts of collaborations that I think we all want to see. That was it.
So that's great, because it's not a question. It's a very wise comment, which could have come from the panel. So Malcolm.
Point to end. Can I ask you to put your hands together and thank the panel?